Feng Weung from UBC, thank you very much for all of your efforts at making this a mobilizable product out into the community of public health professionals. So first off, so today there's going to be two different sessions. First off today is Jeffrey Trieu, who studied epidemiology at SPPH out at UBC, and he is now on staff here at the BCCDC and does data science and data analytics and all sorts of things, and also has been an enthusiastic person helping to make the Radon portfolio go. So thank you, Jeffrey, for all that you've done, and we're very excited to hear what you have to say. So please go ahead.
Thanks for the introduction, but actually David's going to start us off and then he'll pass it to me.
Well, then let me introduce David. The order upside down and backwards. So I have to move my screen here. Without much further ado, then I'd like to introduce you to Dr. David McVea, who is a public health physician working at the BCCDC in environmental health services. He completed his medical training at UBC and subsequently was a member of Canada's field epidemiology program before he came here to join the BCCDC. So David, take it away.
Great, thanks very much for the introduction, and just want to check the screen sharing is all right. Okay, great. So yeah, the way we're going to structure it actually is I'm going to give a brief sort of 10-minute introduction to just the topic in general, and then Jeff will walk us through the British Columbia Radon Data Repository and the public-facing mapping app that we've developed. And then it'll come back to me and I'll talk a bit about how we can use that system to better protect the public from radon. So, okay, so I also just want to take a moment and acknowledge that we are right now on the traditional ancestral land of the Coast Salish people. I think we have audience members from across the country, so let's just reflect for a moment on the fact that we are all probably on unceded traditional land of some First Nations people. We also want to take a moment and thank the funders that have been a big part of this work, particularly Health Canada and CareRx Canada. And Jeff and I, neither of us have conflicts of interest to declare. So, I'm in BC right now, as many of us, I think, are, and we really have had a very powerful example in the past week of the impact of the environment on our health. And our thoughts really go out to all those people affected by the floods that we've all seen here and the impacts that has had on food security, on water quality, on health infrastructure. So we really see a very vivid example of the effect that the environment has on our health. And certainly in BC, it wasn't just that, it's been quite a year for us. We had the historic heat dome over the summer that sadly took the lives of hundreds of vulnerable people in our communities. We had large fires that displaced people, that again disrupted health services, that caused respiratory, cardiovascular difficulties. So we've really had very clear and vivid examples of the power of the environment on our health. But I think all of us here on this call, we're all interested, we all care about environmental health. And so we all know, just as this WHO graphic shows here, we all know that it's not just these significant large disaster type events in which the environment affects our health. In fact, it's every day in every way as we go about our lives, as we move through our homes, as we interact with our neighbors and our friends, the air we breathe, the water we drink, all of it is really impacting our health. Most of it in ways that we don't perceive, we don't pick up on. So we see it's, obviously clear, those big events when they happen, but it's really these smaller, invisible aspects of the environment, or less visible aspects of the environment, that have profound impacts on our health. So today we're going to be focusing in on one of those, on radiation, that you can see on this diagram here. Now, radiation is everywhere, as this nice graphic from Health Canada shows us, whether it's from cosmic rays, from space, whether it is from radioactive particles that make their way into our food supply, our water supply, and a key one that's not shown on here is ionizing UV radiation. Every time we're out in the sun, we are exposed to harmful radiation. And a particular one that, again, we're sort of focusing in even more on one form of radiation that's important to talk about is one that comes from rock and soil, and radon. So radon is formed by, it's a radioactive product. It's formed by the decay of uranium that's naturally present in our soil. And you can see this radioactive chain here as uranium up at the top that we do mine. We use it for energy, to generate energy. We use it for industrial applications, but it also decays and releases radioactive products. And you can see this long chain of radioactive products, and eventually it becomes inert lead after millions of years. But along this chain is radon in red. And a key thing about it is that that's a gas. Many of these others, most of these other are particles, solid particles that may make their way into food supply, water sources, minimal amounts, but they are there. But the key about radon is that it's a gas as it decays. Because it's a gas, because it's present in and being released into the bedrock and the soil, it can enter our homes. And you can see that in this picture here from Health Canada, where all these black arrows are routes, portals that radon can enter our homes. So whether it's through cracks in the foundation, gaps around pipes, even through pipes themselves, there are many ways for radon to enter buildings and enter our homes. Because it's a gas, we inhale it. And so another key feature about radon is that because we're inhaling it, it makes its way into our lungs and can come up into close contact with the epithelium of our lungs. So the radioactive products are low energy, but because we inhale it, they make their way right deep into our lungs and sit right up against that vulnerable epithelium in our lungs. And they can contribute to lung cancer. So it's estimated that about 15% or so of cases of lung cancer are attributable to radon. So second to tobacco smoke is a very key cause of lung cancer in Canada. And so that means that somewhere on the order of 300 or so lung cancers in BC are caused by or attributable to radon. Now, the good news, well, not good news, I guess, but an important feature about radon is that the likelihood of your exposure to it varies quite a bit across the country, across the province. And it's one of the key drivers of that variation is the geology, whether that initial part of that chain, uranium, is present in the soil and the bedrock around your home or not. So you can see on this color-coded diagram here, where darker colors represent a higher likelihood of radon exposure. We have those sort of bands of likelihood of being exposed in the interior and the northern parts, some on the coast also, not so much in the Metro Vancouver area. If you look down at the inset, you can see that that's all sort of a low potential, but directly north of us in the sea to sky corridor, there's the potential for our radon based on geology. There are other very important factors that determine radon risk. Two big ones are shown here. So on the left, you see smoking. That's a very important driver of your risk of radon. And the carcinogens in tobacco smoke actually interact in a synergistic or a multiplicative way to smoke, to radon, sorry. So if you are exposed to high radon and you're a smoker, your risk is greater than either of those two factors alone, greater than just the combination of those. They interact and multiply each other. And the next is housing. So you can see on the right there a picture overlooking Vancouver. And in any community, there's a mix of new homes, older homes, high rises, different sorts of buildings. But because radon is released from the soil and from the environment and makes its way into the lowest levels, people who are living and spending a good deal of time in lower parts of their house are at a higher risk. And if you're living in a high rise, you're at a relatively low risk. And so communities that have a greater mix of high rises or a greater mix of buildings, greater mix of high rises, lower risk of radon-related lung cancers. On the other hand, if you have a greater risk, a greater mix of basement suites, secondary suites in the lower levels of a home, that community would be at a higher risk of radon-related lung cancers. So the good news is radon can be eliminated from indoor spaces. And you can see a diagram of that here in this home. And an exhaust system can be installed through the floors of the home, beneath the subfloor, into the foundation, or into the subsoil below the foundation of the home. And you can really exhaust radon up and out into the outdoor environment where it's harmless. And this can reduce radon quite effectively by between 90 and 95%. It is expensive though. It's about $3,000 or $4,000, depending on various factors, to remediate an existing already built home, to have this kind of system installed. So Health Canada recommends remediating your home if you're over 200 becquerel per meter cubed. That's the measurement that we use for radon. That translates to about a 2-fold lifetime increased risk of lung cancer. We'll be talking more as we go through here about what that measurement means, what that looks like for a community. But just so you know, there's a threshold at which Health Canada recommends you install this sort of system if you have radon above that threshold. So despite the fact that it can be remediated, and despite the impacts of it, awareness of radon is relatively low. So you can see from these Stats Canada reports that somewhere around 50–60% of BC residents in non-apartment homes, so those homes that might be at risk, are aware of radon, but a very small number, maybe 5%, have ever tested their homes for it. And if you look at this rather busy slide here about UV radiation, we see some important differences. This slide also is from Stats Canada. If you look at these circles here, they show different health protection measures that people take to protect themselves from UV radiation. So it depends on whether you're looking at sunscreen or wearing a hat or whatnot, but 30, 40, 50, 60% of people are doing various different sorts of health protection things to protect themselves from UV radiation. I think there's that's an important difference between radon and UV radiation. The burdens are higher for UV radiation, but they're certainly the same order of magnitude of the risk of malignant melanoma and lung cancer. And if you look at this map here of UV radiation risk, you can get a sense for, in part, why that is. It's quite a bit simpler to look at a map like this and see, well, if you're in the lower portion of the country, you're at pretty high risk. As you move north, it gets less and less. It's pretty straightforward. The other important feature is everybody's had an experience or seen a sunburn. And so we've had that experience of the sun harming our skin. And so it makes sense to us that it can hurt us over the long term. So when it comes to thinking about radon, there's some unique features, I think. As we've talked about, there's really unpredictable and variable exposure, depends on housing and geology, a variable risk, depending on things like smoking. There is an effective but expensive and individualized mitigation in this case. So what I mean by that is an individual, what we're talking about here, an individual goes out and decides to test, decides to install the system in their home. That's fairly expensive and it requires somebody to do that and take the initiative to do that. And it's an invisible hazard. You don't see it, you don't feel it, you don't smell it. So in some important ways, it's unlike some things like UV radiation. So we can get away from some of that by using population level interventions for radon protection. So as an example, the province, the country, community can subsidize remediation. They can provide financial support. And Saskatchewan here became one of the first jurisdictions in Canada to do that, to offer a tax credit for remediating your home for radon. We can require remediation of rental homes. We can require disclosure about radon levels during real estate transactions. We can remediate public buildings. We can educate, raise awareness among the public, health professionals. So these are all things we can do at a population level for radon protection. But because of all the variability of the exposure to radon, targeting, prioritizing, motivating people to respond to this invisible risk does really require data and information about where the highest risks are and how to act on those. So with that in mind, I'm going to transfer over to Jeff at this point, and he's going to take us through an initiative that we've gone through in BC to address some of these things.
All right, thanks, David. Just going to share my screen here, and I'll begin when I get the A-OK that we can see full screen PowerPoint there.
Yes, we can see it, Jeff. Thank you.
Awesome, thanks, Henry. Okay, so yeah, as David laid out, we have a need to gather radon exposure information. And specifically what we can look at is indoor measurement data. Radon is relatively easy to test for and has been facilitated in bulk by a variety of parties here in BC. And I'm sure this is the same in many other jurisdictions. So this is to say that there's quite a bit of data out there already. The challenge is that all this data is held separately. So this project was an effort to compile this data into what we've called the BC Radon Data Repository, or BCRDR for short. At project conception, what we envisioned was a one-stop shop for indoor radon measurement data in BC, so that we can essentially complete some of the data cleaning and integration legwork for us and others, and so that we can collectively better understand and reduce the risk of radon in the province. So this all started with us reaching out to all known BC Radon data holders and inviting them to participate. Participation is voluntary and formalized with a data sharing agreement. The agreement frames us as repository data. And what this means is that, excuse me, data providers continue to own their data, and we would only use the compiled data as outlined in the agreement, which in broad strokes would be for research and health protection work. Someone would not be able to re-identify a person or building with reasonable accuracy with this data. So we didn't compile any homeowner names or phone numbers, nothing of that sort. And only geographic boundaries or anonymized point coordinates were retained as spatial units in the repository data. And I'm going to touch on this in a little bit more detail in a moment. But the last main feature of the repository is that external parties can request access to the non-identifiable data. We have a formal application process for this, and data would only be released for research and health protection work. So essentially the same type of uses that we would have with this data ourselves. So of course, confidentiality is a key priority for us as the data steward and for the data providers as well. Now, part of this is done through operational pieces, how the data is stored, how internal access is granted and documented, the external request process, all those sorts of things. And again, those are documented in the data sharing agreement. From a data management perspective, the main thing we have to deal with is the spatial unit. Again, we didn't compile any person level information. So we needed to find a geomasking method that renders the data non-identifiable while still allowing for flexible and valid use. So keeping in mind what type of information data providers would have collected, we asked for address strings or 6-digit postal codes. We geocoded these to point coordinates and applied a random systematic jitter in any direction to a degree inversely proportional to the underlying population density. So this is called donut geomasking, and as you can see from that textbook figure there, there's donuts of a variety of sizes. In other words, observations in sparsely populated areas would be displaced relatively far from their original location, and observations in densely populated areas would be displaced relatively close. I'm going to explain this in a little bit more detail and try to just hammer it home with a quick example. So this is where we work at the BC Center for Disease Control here in Vancouver. If we were to geocode the postal code to a point, you would get that those coordinates there, and that's the blue dot, kind of near the center. we got the underlying population density from the census dissemination block and used that to calculate the minimum and maximum displacement radius, or the donut size. The black dot is a randomly generated point within the donuts. And for those not very familiar with this area, it's in a fairly dense urban area. Mostly to the south there is mid-rise residential buildings. So you really, in this case, don't have to displace the original point that far to render it non-identifiable. And just to illustrate that, here's a smattering of other postal code points in the area. Of course, though, in remote areas, this donut would be quite large. And so to achieve anonymity, we would have to tip the scale over a little too far, and then these coordinates would lose their validity. So we capped the maximum possible displacement to 500 meters. Anything that could be displaced farther than that, we only retained its broader geographic boundaries, like a forest rotation area, like a local health area. And 500 meters was chosen as a reasonable amount of error that could be accounted for in any sort of geographic linkage. So to date, the repository has 13 external contributors representing a wide variety of roles in the radon world. We have government agencies here, industry groups, and community and advocacy organizations. It's important to note that some of these groups collect data on an ongoing basis, and our data sharing agreements cover that as well. At the moment, the repository holds over 17,000 unique measurements in over 13,000 unique buildings. Most of these are in residential settings and done with a long-term alpha track detector. And most of these we were able to geocode with the method I just described there. This is a local health area map to show where we currently have data. I capped the scale here at 200. Just so we can see variation at the relative mid-level, but I will note that some of these areas have quite a bit more than 200 at Prince George, Central Okanagan, Castlegar, for example, well into the thousands. But again, I just wanted to show that, relative mid-level variation there. And the main point I want to drive here is that most of our data at the moment is in the provincial interior. And this is where radon is known to be more of a problem, given the underlying geology, as David was describing earlier, and where testing efforts have been concentrated to date. So a common resolved spatial unit for geographic linkage is postal code. So another way to think about data availability and spatial coverage with higher resolution is the proportion of postal code points that have an observation nearby. And I apologize for the fairly small text on this slide here. Hopefully it's decently readable. This is the percentage of postal codes that have a given minimum number of unique building measurements that we were able to geocode within 1 kilometer, and is stratified by health authority. So in the top 2 panels there, you can see that in the north and in the interior, the degree of linkage is actually quite good. We have in the ballpark of about half of the postal codes have at least 20 measurements within a kilometer. And if we were to have a less strict inclusion criteria, say minimum 5 measurements, this jumps up to 70, 90%. As you expected from the previous map figure there, this drops down quite a bit in Fraser, Coastal, and the island. So a limitation with this compiled data is that it's largely not randomly sampled. These are mostly a convenience sample, government agencies and community groups providing test kits to all those interested in their target communities. The only randomly sampled source that we could compare to across the province is Health Canada's Cross Canada survey from 2012, I believe. Oh yes, that's the reference right there. And they cluster random samples at the HSDA level, which is the boundary shown here. So those are on the left, and the remainder of the unique building residential measurements within HSDA are on the right. So a couple takeaways here. The general geographic distribution is the same, and we're happy to see that at a high level, we're still seeing, as expected, elevated concentrations in the provincial interior. Across the board, though, in the non-random convenience sample, though, the distributions are higher than the Cross Canada survey random sample. And that may show that some selection biases are coming into play here. Example could be someone's testing at their home, finding a higher reading, chatting with their neighbors, and they going to test themselves. We do know that there's building to building variation, so that bias may wash out. But overall, this is to say, this is an important limitation to consider in use of this data, and something we're actively exploring in terms of how to best communicate that. All right, so this is one of our recent uses of the compiled data, hot off the press. We just released it for November Radon Awareness Month. It's a web app displaying radon concentrations across the province. And the goal here is to increase awareness and knowledge about radon here in BC. So I'm gonna jump out of here. Hopefully you can all see my browser there. Is that correct? So the data presented in the Map app draws from the repository, but it's limited to measurements in residential buildings. When there's more than one measurement in a building, we only took one in the lowest floor at an unmitigated state if indicated. We then rounded all the concentrations to the nearest 10 becquerel per cubic meter, fit a log normal distribution for each given area, and use these to estimate all the summary statistics presented in the map. This way, regardless if an area has 20 measurements or 2,000, we're pulling these statistics in a uniform way. That being said, the modeled distribution summary statistics approximate the observed data distribution statistics across the board. So here it defaults to health authority, the 5 BC health authorities here, and you can toggle between displaying the estimated median or 95th percentile concentration in any given area. These are summarized into these 4 concentration bands on the bottom right. These align with Health Canada guidelines for action, that being to mitigate your home within 2 years if you find a reading above 200 becquerels per cubic meter, and within 1 year if you find a reading above 600. Gray indicates that are less than 20 measurements in that given area to gather these summary statistics. And you'll see that as we go down to the smaller geographies. And I think this can be quite useful in itself to show where there has been less known testing to date. So we have health authority here. We can go down to health service delivery area, local health area, and down to municipal boundaries. Municipal boundaries don't cover the extent of the province, so you'd have to zoom in to see it better. The numbers in the blue dots show the number of municipalities in that approximate region at that given zoom extent. So we zoom further, we can see it a little bit better. So Vernon here, for example. And you can also notice as you zoom closer, there's a base layer, and the purpose of this is to give context to all of these geographic boundaries and make this all more interactive and meaningful for a general audience. With that in mind, there's a couple other search features here as well. The crosshairs at the top left here will zoom to your location if you allow your browser to know that information. You can see here I have it blocked, so it doesn't do that. But typically there's a prompt that will come up for that. The magnifying glass is your typical search bar to zoom to a landmark or address of interest. When you click on any region in whatever geography you select, this shows more information about that area. So here is the Interior Health Authority area, for example. We have a 10 by 10 pictogram displaying the estimated proportion of homes within each concentration band. And what's really important here is this bolded text to remind users that the community level estimates here don't replace the value in testing one's own home. And in fact, it's recommended that every home be tested. As you scroll down, we have to the point lung cancer risk estimates. These are the likelihood of developing lung cancer in one's lifetime if they lived in a home within each radon concentration band for non-smokers on the top, and we have smokers on the bottom. These are drawn from this study here from Dr. Jing Chen of Health Canada. And what that study does is it takes established radon lung cancer risk estimates and applies them to Canadian lung cancer and smoking data to get these risk estimates here. What we want to show is the synergistic effect of the 2 exposures on lung cancer risk. And even for smokers in low radon exposure environments, lung cancer risk can still be quite high. So the app lives here. It's a web application, fairly short URL, but can also be found on our newly updated Radon webpage. I'm just going to pop back to PowerPoint here just to summarize this quickly before ending my section here. Hopefully you can see my slide there again. But yeah, you can find the updated webpage on this very simple bccdc.ca at /radon. Again, the map app can be found here. There's more information about the data that feeds it, the repository as well. There's basic intro to radon information here, testing and mitigation information, and links for further resources elsewhere. For example, where to find a certified mitigation professional, where to buy a test, for example. So that's all I have for you all here today. And I will either be passing it back to David now or taking questions, whatever fits best for the session.
I think we should stop if you don't mind, just because there are a few questions around map granularity that I think if we could just stop for 1 second, we won't take too long.
Oh, for sure.
I promise. Okay, there's lots of questions coming in fast. So from Kelly McDonald at Interior Health, why is the Interior Health region so large? Can the map be more focused to local health areas so that the data can be more useful to more regional folks?
Yeah, this question was probably asked earlier, but as I'm sure everyone saw, we do have the smaller geographies there, local health area and municipal boundaries as well.
So that's already available on the map. We just have to set the priority on the left-hand side.
Yeah, it's yeah, the toggle on the bottom left. Health authority, health service delivery area, local health area, municipal boundaries.
Is the app, does it work on all different types of devices?
Yeah, so it's just a web app to type into your web browser, Google Chrome, Internet Explorer, whether you're on a desktop computer, laptop, or cell phone.
And confirming that it is indeed free?
Yes, it's free. Yeah.
Okay.
It's a public resource. We hope that overall we're just trying to increase awareness of radon and increase knowledge about it.
Okay, this might be a question for David, so if you want to defer, but are you intending, so I'm assuming is the BCC going to be updating lung cancer risk estimates by linking radon data to lung cancer data in the province?
Part of the goal of having this high resolution aggregated data is to be able to tie exposures to outcomes, to lung cancers. So right now when that's done, it's usually done at a fairly zoomed out level, saying you live in, interior health. There's slightly more lung cancer than we'd expect there. That's due to the higher radon level. But that's, an ecological survey that's very zoomed out. So with this data, we can zoom in much more and perhaps assign in a very careful way to protect confidentiality, assign each case of lung cancer or radon exposure and do long-term case control type tests. So that's under discussion.
So this is the first step to make such an analysis possible.
Right. First, you need to have a high resolution map to be able to assign people a more accurate radon level.
And at this point, I'll give a shout out to Dr. Sarah Henderson, who in 2013 and again 2015 has published some studies, just correlational studies looking at lung cancer rates and radon levels in a very preliminary way. So if people are interested, that's publicly accessible data as well. Okay, I think I'm going to stop it here, but please keep questions coming in the chat and we'll turn it over. Thank you very much. We'll turn it over to David at this point in time.
Great, thanks very much. I'm loving the discussion, so I may cut short a little bit of my second section here. Switch presenter back to me. Okay, great. So thank you, Jeff, for taking us through that. And as I said in the first portion of my section there, radon-related risk varies dramatically due to indoor radon concentration, as we've just looked at, as well as smoking status. And this infographic from Health Canada really emphasizes that by showing that for the same level of radon, a smoker has a 1 in 3 risk of lung cancer as opposed to a 1 in 20 risk of lung cancer. So 5 or 6 or 7, somewhere in that order, increased effect of radon due to the interaction with smoking. And in British Columbia, in addition to radon changing throughout the province, smoking rates changed throughout the province too. So overall, the smoking incidence in BC is about 15%, but it ranges from 22, 23 in the north to 12, 13% in Vancouver Coastal Health. So there's 2 factors that really impact that affect the impact of radon on a community. So with that in mind, thinking about how deaths due to radon can be prevented, but it's expensive at an individual level, and it varies across BC due to different smoking and radon rates. We have been working and seeking to determine the effects of these 2 factors, smoking rates and regional radon levels, on the cost utility of radon remediation in BC. And our hope is that communities can look to the high resolution spatial data about radon and really get a sense of the exact risk within their community. So I'm going to take you through some of what we've done. So to do this, we've generated a model that models 100,000 homes, and we assume 2 adults per home. And we draw radon concentrations from these empirical BC distributions that we have. And then we model the radon mitigation by reducing radon levels by 90%. And for cost utility estimates, we use sort of industry standard costs. And then we can calculate cases of lung cancer and lost quality adjusted life years. We let this model sort of run along for 60 years, and we can accumulate and see what the impact is. So let's take a look at what sorts of things we can see in this model. So as an example, we can test various remediation strategies. So in this figure here, you see the cumulative prevented lung cancer cases in BC by different radon remediations per 100,000 homes. And on the x-axis, you have years, and on the y-axis, you have prevented lung cancer cases. So there's not any guidance right now from any public health agencies that I know of that all homes should be remediated across the province. But we can model what that would look like, and that's the black line. We can model the current recommendation, that's the blue line, and we can sort of model what's in between, and that's the gray line. And you can see there, it's effective to remediate homes, certainly, but it's an interesting fact that most cases of radon attributable lung cancer in BC will be caused by a low level of radon, just because the vast majority of exposures are at low levels. That's not to say that if you have a low level, you're at high risk. We know the low levels are fairly low risk, but there's just so much more of them and so many more of them that they do generate the bulk. But it's not really practical or effective to think of every single case in every single home in the province. But we can, as an exercise, kind of see what it looks like. We can switch that around a little bit too, and we can look at the effects in different communities, different radon distributions. So now what you're looking at in blue is what happens if we follow the Health Canada guidance across all BC. How many lung cancer cases are averted over 60 years? And we can look at what would happen in a high radon region. So instead of all BC, something like you might see in the interior, for example, the same guidance. Because of the higher risk in that community, you can really see the difference in preventing 2 or 3 times as many cases of lung cancer. So, we've seen in this map that there's lots of different levels of radon across the province. They change depending on where you are. So we don't want to have just 1 or 2 distributions that communities can look at. So what we have done actually is modeled 12 different distributions of radon across that are reflective of areas across the province. So on this figure, I show 3 of them just to kind of give you an example of what you're looking at. In black, a low radon community. In blue, a mid-range radon. And gray, a high radon community. This is 3. We're actually working with 12 of them. And we can, using those, model out various things that happen. So let's take a look at some of the outputs here. So what you're looking at now is a bit different from what we looked at before. Here on the x-axis, you have those different communities. So you're looking at the geometric mean radon concentration. Geometric mean, you can think of it like the mean. It's just a way of measuring the overall radon distribution in that log, what we call log normal distribution. So as you move from the 0 to the 200, you're moving from a low radon community to a high radon community. And on the y-axis, you have the number of radon attributable deaths over 60 years per 100,000 homes. So these are deaths that are specifically attributed to radon. And it's not surprising, you can see that as you move into a community that has more and more radon, you have more and more deaths due to radon. But a policymaker, a homeowner, anybody can kind of look at this and get a sense of what the risk is for their community given their specific radon distribution. We've also been working on the cost utility of radon remediation in these different settings. So cost utility is a measure of the benefit that you get to public health or to health by spending money. And it's a way of seeing how many dollars you have to spend to get one quality adjusted life year benefit. And that's what this curve shows here. So as you move from a low radon region to a high radon region, your cost utility improves and improves really quickly at the low areas, and then it kind of flattens out. And I will say, if you look at the scale of this axis, even at the lowest areas, it's about $20,000 in your cost per quality, and that's actually quite good compared to many clinical interventions, many public health interventions. That's a pretty good, pretty effective cost utility ratio. So just returning to this now, I've walked you through that first panel, that number one, thinking about the indoor radon concentrations and how that impacts the risk. But the second panel is important too, the smoking status. So to consider that and help communities grapple with that, we've also begun to model the effects in communities with different smoking rates. So now what we're going to be walking through is the same thing in terms of radon, 12 different radon communities, but crossing that with 3 different smoking communities. So really we'll have sort of 36 across these curves, 36 different model communities you can imagine it as. And the smoking rates are a low smoking community, which is 20% below the BC average, mid community, which is at the BC average, and a high community, which is 20% above the BC average. So this curve is familiar. It's the one we just looked at a few slides ago, but it's got 2 more lines on it now. So now it has a community that is a low smoking rate community and a high smoking rate community. And you can see the impact of those on the radon attributable deaths. And I do want to emphasize these are radon attributable. It's not, you would expect that if you go from a low smoking prevalence community to a high one, you'd have more cases of lung cancer and more deaths. But these are specifically caused by the interaction of smoking and radon. And the lines widen as you get into higher and higher radon concentrations because of that interaction and the multiplicative effect. And so if you're in a low radon community with a high smoking rate, the impact of radon in your community is actually, you can kind of look across that line and see it's the same as a low radon level in a high smoking community. So it's really not just one or the other, it's the interaction of these two that governs a community's risk. Then looking at the same cost utility curve that we looked at before, again, adding 2 more lines to it, one for the low smoking rate and one for the high smoking rate. And across any given radon concentration, the cost utility is higher if you're in a community that has higher smoking rates. So what does this mean for BC? What this plot is showing now is the relationship between smoking rates at the HSDA level and radon levels in BC. So on the x-axis, same scale we've had before across the past few plots, and on the y-axis you have the percent ever smokers in a given community. And so there are communities, as you can see, that are both high levels of smoking and generally high levels of radon. There's also communities that have fairly low levels of radon, as we've been able to determine through our testing and aggregating, but quite high levels of smoking. So these are communities where just looking at radon may give a false sense of security, or a sense that radon isn't an issue in this community, but because of that interaction, it might be more of an issue than it's recognized. So because of the powerful interaction of smoking and radon, we've actually begun to look a little bit of what happens to something like cost utility if we just look at smokers. So instead of prioritizing everybody over 200 becquerel per meter cube for remediation, what if we just focused on smokers? You can see it's a really powerful effect. So those low lines at the bottom there are the cost utility of remediating the homes of smokers over 200 becquerel per meter cubed. There's a couple of interesting features about this. First of all, it's really quite flat. The cost utility is the same across any radon concentration, and it's really quite cost effective even at low levels. So this emphasizes that for any community, regardless of the radon level in that community, it's important and it's effective to think about radon and to encourage remediation. At the lower edge of the spectrum of radon, it might be important to focus just on smokers. So, what could that look like? I think research is important. So to understand the awareness of radon among smokers and non-smokers, there's not great BC specific data, and overall in different jurisdictions, it's mixed about how smokers and non-smokers are aware of and act on radon. Radon could be discussed at smoking cessation clinics by clinicians when talking to people who come in to talk about smoking. Information about radon can be included with tobacco or with smoking cessation products. And a really interesting one to think about, I think, is the integration of radon levels into lung cancer screening for smokers. So it's becoming recommended that smokers receive, I think, every 10 years, a low energy, low dose CT scan to check for radon, check for lung cancer. The importance of that screening might really depend on where somebody lives, whether they happen to have their own radon level in their home, or if they live in a community that has high radon. It may tip the balance of that screening program towards, yes, we should screen you or not. Now, two things I want to emphasize as I'm wrapping up here. Certainly, for smokers, the most important thing across the board is to stop smoking. It's not just lung cancer that smoking causes, it is or contributes to. It's heart disease, it's COPD, it's all sorts of other malignancies. So I'm not in any way suggesting that we want to focus on radon reduction for smokers. Not at all. Smoking cessation is still a priority, but this is maybe one part of reducing the burden of lung cancer and smoking due to radon. And secondly, I've been speaking about a particular aspect of radon protection, and that is sort of an individualized testing, deciding to remediate your home, testing again to make sure it worked, and how that cost utility is affected by these various factors. It doesn't necessarily apply to the population level protection programs we were talking about before. So upgrading and maintaining modern building codes, upgrading and remediating public buildings, ensuring that newly constructed homes have radon tests so that buyers are aware of the radon levels and their risk, increasing awareness, education, training in general for radon. These are things that are still crucial and very important to controlling and protecting the public from radon. So I'm going to summarize the past 50 minutes in 3 bullet points, I hope. So the BC Radon Data Repository, it's a useful tool for the public, we hope, for policymakers, for researchers to better understand radon-related risks. The cost utility of radon remediation program, it varies based on both smoking and radon levels in a community. And we hope that the detailed radon levels that we're presenting will be useful for this sort of thing. And thinking about smokers for radon awareness in particular, it has a very high cost utility. And for communities that are at low radon levels, it can be a very important and a very useful way to continue to address the burden of radon within those communities. Jeff and I both have a fairly long list of acknowledgements. Lots of people have worked on these projects. Jeff, you might want to just touch on all the industry and government collaborators to the radon repository. I think they're listed in that second column there. Thank you all very much for your time, and both of us can be reached at those 2 email addresses if you have any questions.
Hey, David, thank you very much. So there's been some fast and furious chats going on in the questions section, and thank you to Jeff for answering a number of those as they came along. So yes, please, everyone, we have a few minutes now, not a lot of time, but some. So it's a question from Anita Eli. Similar to images of impacts from smoking being required on tobacco products, could this format also be used to raise awareness of radon and the synergistic effects of smoking and radon, to include this on the tobacco package? So you might have thoughts on this, and I know there's people from Health Canada in this session, so they may want to send something in the chat too. But David, what do you think about that idea?
Yeah, it's a really interesting idea. The only thing I would say to that is that sort of back to that idea about, well, radon and lung cancer is one aspect of the harms of smoking. So I wouldn't want to dilute all of the other impacts of smoking that are important that come through in those messages.
Okay, I have a question for Jeff. Jeff, is the data from the database shared with the CNRPP, that's the Canadian National Radon Proficiency Program, which certifies professionals, to help inform the national map? Are you connecting with that group?
We have a data sharing agreement with that group going from them to us, but that's solely with the 100 test kit challenge data, not the crowdsourced data collection, if that's the right way to describe it, and not currently the other way around. But as mentioned, we have a data request process, and happy to have those conversations if there's interest.
Okay, and I have a point I'd like to bring up. Thank you for David, and it's around the use of how we address whether or not people are smokers. So can you comment on what is meant by an ever smoker?
Yes, so an ever smoker, the accepted definition of that usually is somebody who has smoked 100 cigarettes in their lifetime, regardless of whether they are currently smoking or not. We use that definition for these models. The model as developed, it's an EPA model, and that's how it's calibrated. That's the input to it, is ever smoker. And that scatter plot that I showed you was ever smokers versus radon levels. It's not, I mean, there's trade-offs to using ever smoker or current smoker, but that is the way this model is calibrated, and using ever smoker does capture that risk. You know, I'm not a smoking expert, but my understanding is the sort of very bimodal. You either smoke very little, a few cigarettes in your life, or you have smoked a large number of cigarettes, and that impact does linger with you for some time, and that's sort of the logic behind it. Over time, we might be able to input different measures of smoking.
I think this is an important point, because there's lots of people who, you know, no longer consider themselves smokers because their smoking history was in the past, but it still shows that there's an elevated risk for people even if they've quit.
If you had, yes, it is certainly true that the risk would be lower for somebody who's a remote smoker as compared to a current smoker, but the risk of a remote smoker is higher than a never smoker.
Great. I think it's really helpful to have those messages be so clear for people who are working to promote radon awareness for others. Okay, I'm just gonna quickly check the chat. Was there anything else that either of you wanted to add? We only have like a minute left. So is there anything else that you thought of that you wanted to add?
Not for me, just thanks everybody for coming. And this is I guess you could call it a green, I don't know what the terminology is, never remember it, a living project. So the nice thing about the map is it's always getting new data, and it's always going to have we can add new features to it in a day or two. So we plan to keep doing that. Maybe we'll have interactions of smoking and radon or something like that over time.
That's a good point. I forgot to mention that if you are a data holder or you'd like to be part of this initiative in British Columbia, please do contact Jeffrey because it is a living project. I also would like to challenge some of the other provinces to consider adopting such a program themselves. I think it's very useful at the provincial level to have this kind of a resource. And I'm sure that Ontario, Quebec, or some of the other provinces might be able to consider. So I think that we could probably have conversations with them about how to do something similar in other places. Yes, you can have a copy of the presentation. I'll let Anna's responded, yes, there'll be a copy of this webinar that will be up on the website. And I think that brings us to the end.